Welcome to our comprehensive guide on arterial blood gas, or ABG, interpretation. In clinical practice, understanding ABG values is essential for diagnosing and managing a variety of respiratory and metabolic conditions. This video will walk you through the basics, from normal ranges to identifying primary acid-base disorders, compensation mechanisms, and the causes of hypoxemia. By the end, you'll be able to confidently interpret ABG results and apply your knowledge to real-world scenarios. Let's begin by exploring why ABG analysis is so important for patient care and what information it provides about the body's physiology. Before we dive into the details, let's clarify our objectives. By mastering ABG interpretation, you'll be able to determine if arterial blood gas values are within normal ranges, identify primary acid-base disturbances and mixed disorders, assess whether compensation has occurred, and distinguish if hypoventilation or other mechanisms are causing hypoxemia. These skills are crucial for making informed clinical decisions and ensuring optimal patient outcomes. Keep these goals in mind as we move through each section of the video. Arterial blood gas analysis provides two main pieces of information: the acid-base status of the blood and the levels of oxygen and carbon dioxide. These values reflect how well the lungs and kidneys are maintaining the body's internal environment. The main components you'll look at are pH, PaCO2, HCO3, and PaO2. Each of these tells a story about the patient's respiratory and metabolic function. Understanding their interplay is key to accurate interpretation. The bicarbonate buffer system is the primary mechanism the body uses to maintain acid-base balance. The chemical equation $H plus HCO 3 left-right arrow H 2CO 3 left-right arrow H 2O plus CO $2 illustrates how hydrogen ions, bicarbonate, carbonic acid, water, and carbon dioxide interact. This system is governed by the law of conservation of matter, meaning that changes in one component will affect the others to maintain equilibrium. This principle is foundational for interpreting ABG results. To quantify the relationship between pH, bicarbonate, and carbon dioxide, we use the Henderson-Hasselbalch equation. pH is gelijk aan pK plus log Frak HCO 3 PaCO 2. This equation is central to understanding acid-base disorders. If any one of these variables changes, the others will adjust to maintain balance. This is why, when interpreting ABGs, we focus on pH, HCO3, and PaCO2 as the core components. There are four primary acid-base disorders: respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Respiratory disorders originate from changes in ventilation, affecting CO2 levels. Metabolic disorders stem from non-respiratory sources, such as the kidneys or gastrointestinal system, affecting bicarbonate. Each disorder has distinct causes and clinical implications, which we'll explore in detail. Respiratory acidosis occurs when alveolar ventilation decreases, leading to CO2 retention and increased acidity. Common causes include lung diseases, CNS depression, or neuromuscular disorders. In contrast, respiratory alkalosis results from increased ventilation, causing CO2 to be blown off and blood pH to rise. This can be triggered by anxiety, pain, or certain lung conditions. Recognizing these patterns is essential for accurate diagnosis. Metabolic acidosis is caused by an increase in acid or loss of bicarbonate, often seen in conditions like diabetic ketoacidosis or severe diarrhea. Metabolic alkalosis, on the other hand, results from excessive loss of acid or gain of bicarbonate, such as with prolonged vomiting or overuse of antacids. Understanding the underlying cause helps guide appropriate treatment. Sometimes, patients present with more than one acid-base disorder at the same time. These mixed disorders can involve combinations like respiratory acidosis with metabolic alkalosis, or even triple disorders involving both respiratory and metabolic components. Identifying mixed disorders requires careful analysis of all ABG values and understanding the expected compensatory responses. To interpret ABG results, you must know the normal reference ranges. For adults, normal arterial pH is 7.36 to 7.4. Parcodos is 3 to 6 to 46 mHg, ox CO3 is 23 to 27 mEK, L, and Paodos is 80 to 100 mHg. Base excess ranges from -4 to +4. Values outside these ranges indicate an underlying disorder. Always compare your patient's results to these standards. As air moves from the environment into the lungs and then into arterial blood, the partial pressure of oxygen decreases. Dry inspired air contains about 21% oxygen, resulting in a partial pressure of 160 mm Hg. This drops to 150 mm half in the trachea due to humidification, then to about 110 mm half in the alveoli after mixing with CO2, and finally to around 100 mm halving in arterial blood due to incomplete diffusion. Understanding these steps helps explain why arterial oxygen is lower than inspired air. Each acid-base disorder has its own set of causes. For example, metabolic acidosis can result from renal failure, ketoacidosis, or toxin ingestion. Respiratory acidosis may be due to CNS depression, neuromuscular disorders, or lung disease. Metabolic alkalosis often stems from vomiting or diuretic use, while respiratory alkalosis can be triggered by anxiety or hypoxia. Recognizing these causes is vital for targeted treatment. The body uses three main systems to compensate for acid-base disturbances: buffers in body fluids, the respiratory system, and the kidneys. Buffers act almost immediately. The respiratory system can adjust CO2 within minutes, and the kidneys provide long-term regulation by altering H+ and HCO3 excretion. Compensation helps minimize pH changes, but rarely returns pH completely to normal, except in respiratory alkalosis. The anion gap is a useful tool for evaluating metabolic acidosis. It is calculated as $Na plus Cl HCO3 $. An elevated anion gap suggests the addition of acids, as seen in renal failure or ketoacidosis. A normal anion gap points to causes like diarrhea or renal tubular acidosis. The anion gap helps detect mixed disorders and guides therapy. A systematic approach is key to interpreting ABGs. First, check if each parameter is within the normal range. Next, determine the primary disorder and whether compensation or mixed disorders are present. Always check the pH first, then PaCO2, HCO3, and finally PaO2. This stepwise method ensures you don't miss important details. There are helpful rules of thumb for refining your ABG diagnosis. For acute respiratory acidosis, a 10 mm Hg rise in PaCO2 increases HCO3 by 1 mg/L. For acute respiratory alkalosis, a 10 mm H drop in PaCO2 decreases HCO3 by 2 mg/L. If changes are greater, compensation or a mixed disorder may be present. Also, in chronic respiratory acidosis, HCO3 often exceeds 30 meq/L. Hypoxemia means low oxygen in arterial blood. The main causes are alveolar hypoventilation, diffusion impairment, shunt, and ventilation-perfusion mismatch. A fifth cause is decreased inspired oxygen, such as at high altitude. When interpreting ABGs, compare the decrease in PaO2 to the increase in PaO2 to determine if hypoventilation is the main mechanism or if other lung pathologies are involved. Oximetry measures the percent of hemoglobin saturated with oxygen, SO2 or SpO2, while PO2 is the partial pressure of oxygen in arterial blood. These are not the same. For example, a PaO2 of 55 mm Hg is a critical threshold for stopping exercise, but a SpO2 of 55% would correspond to a dangerously low PaO2. Always interpret SpO2 and PaO2 separately and understand their clinical significance. The oxygen dissociation curve plots PaO2 against SO2, showing how hemoglobin saturation changes with oxygen pressure. At normal body temperature and pH, the curve is sigmoidal. Small drops in PaO2 above 60 mmHg cause little change in SO2, but below this, saturation falls rapidly. This relationship is crucial for understanding oxygen delivery and the risks of hypoxemia. ABG values can be classified as acceptable, poor, or very poor. For example, a pH of 7.4, PaCO2 of 40 mm HCO3 of 25, MEQL, and SpO2 of 95% are considered normal. Poor values include a pH of 7.2, PaCO2 of 60 mmHg, HCO3 of 15, MEqL, and SpO2 of 90%. Very poor values are more extreme and indicate severe derangement. Rapid deterioration is more concerning than gradual changes. In summary, ABG interpretation is a vital skill for clinicians. By understanding normal values, primary and mixed acid-base disorders, compensation mechanisms, and the causes of hypoxemia, you can make informed decisions for patient care. Remember to use a systematic approach, apply the rules of thumb, and never confuse SpO2 with PaO2. With practice, you'll become proficient in ABG analysis and improve patient outcomes.